support inequities. I'm very excited that today we're going to hear about an IHI Health Equity Accelerator that was formed to provide consistent, standardized, and evidence-based measurement guidance to address health equity and facilitate benchmarking and comparative performance, as well as to create an accountability framework. We're going to hear about the history and progress of that accelerator event. And then the panel is eager for your feedback as they work to finalize the guidance and produce recommendations. So spoiler alert, you guys are all here for a group activity. And then we'll turn to questions and answers. So without further ado, I will introduce our illustrious panel. First up, we have Dr. Kristen Azar, who is the inaugural executive director for the Sutter Health Institute for Advancing Health Equity, where she leads an experienced multidisciplinary group to incubate innovative solutions to eliminate health disparities. Kristen has led numerous published studies in the areas of health disparities, health equity, cardiometabolic disease, and mental health. She has diverse clinical experience as a public health and preventive cardiology nurse in and outside of the United States. Whitney Haggerson is Vice President of Health Equity and Medicaid at Providence, where she works with leaders across Providence's 7-state footprint to eliminate health inequities and better care for patients with Medicaid and those who are uninsured. This is done by taking a data-informed and evidence-based approach to meet people's holistic needs. A champion for female empowerment, Whitney co-founded Providence's first ever women's caregiver resource group to support gender equity at her workplace. Rachel Harrington is Assistant Vice President, Health Equity Sciences at the National Committee for Quality Assurance, where she leads NCQA's efforts to generate and implement evidence to advance equitable, high-quality healthcare for all. In this role, Rachel directs the Equity and HEDIS program and serves as the scientific lead on multiple federal and foundation-funded projects. A nationally recognized expert in equity and healthcare quality, Rachel has also worked extensively in the areas of risk-adjusted utilization, medication safety, and economic modeling and patient engagement and research. And finally, Nikki Tennermann is Senior Project Director at the Institute for Healthcare Improvement, where she leads North American networks and support projects related to health equity, particularly with payers and health plans. Nikki is a health and human services leader with a background in complex care, early childhood development, and diversity, equity, and inclusion. Nikki maintains a small telehealth private practice in the greater Boston area that focuses on BIPOC and LGBTQ mental health empowerment. Please join me in welcoming our incredible panel. Hand it over to you.
Thank you. Good morning, everybody. I'm Nikki Tennermann. I am a biracial, shorter woman wearing a purple dress and white glasses, and I'm happy to be here with you all. I use she, series pronouns. This is our agenda for today. We're going to talk a little bit about the Health Equity Accelerator, how it formed. We're going to walk through the current landscape, why we're took this on. Then we'll go into the data, what we've done together. And then as Erin alluded to, we'll have some interactive activities with you all. So we wanted to start with an overview and timeline of this work. In 2023, Sutter Health participated in a Vizient survey related to health equity measurement. And then at this very conference a year ago, Sutter, Providence, and UChicago Medicine noticed that there was variation in how they were measuring health equity. Those organizations were all part of the IHI Leadership Alliance, and they approached IHI if we could help convene a group of healthcare leaders to coalesce around recommendations and guidance for health equity measurement. The IHI Leadership Alliance is a network of health C-suite executive leaders from 60 healthcare organizations across North America. And I get the pleasure of helping to lead with the Leadership Alliance. And we were delighted to collaborate with these organizations. The Health Equity Accelerator started in the fall of 2023. That's when Kaiser Permanente School of Medicine and NCQA joined our work. We were able to survey over 20 healthcare leaders from over 20 healthcare organizations about their approaches to health equity measurement. And then we also conducted roundtable interviews with close to 80 leaders from the Leadership Alliance at our fall meeting. Through the advocacy of Kristen from Sutter Health, we were able to obtain sponsorship from Genentech for a 2-day retreat that we came together at the end of March. So we brought members from the Health Equity Accelerator to Sutter's facilities in San Francisco and started to make sense of the data and evidence that we will review with you all shortly. And then that brings us here to today and what we're going to present with you all. The Health Equity Accelerator has met monthly since the fall. So I talked about the container of an accelerator. The IHI Leadership Alliance hosts accelerators to bring together a small cohort of healthcare organizations to come together around perhaps an untested idea, a measurement need, a gap in the field to, as the name alludes to, accelerate progress toward resolving that issue and improving it. The goal of the Health Equity Accelerator has been to create a best practice recommendation for health equity measurement, and then to disseminate it widely across the healthcare ecosystem with some illustrative best practices. And we're going to talk about, again, what we've done together and how we've gotten there. So the Health Equity Accelerator is advised by Sutter Health, Providence, UChicago Medicine, NCQA, and the Kaiser Permanente School of Medicine with IHI as the convener. And then I will read for accessibility the accelerator group. It includes Alliance Chicago, Blue Shield of California, CARE South Carolina, Community Health Plan of Imperial Valley, Greater Baltimore Medical Center, Inova Health System, Nemours Children's Health, Northern Light Health, Ocean, Parkview Health, Partnership Health Plan of California, and Zuckerberg San Francisco General Hospital. And as you can see, the accelerator includes a diverse representation of type of healthcare entity, federally qualified health centers, health plans, pediatric institutions, large integrated medical centers, and also diversity of setting from the South, Pacific Northwest, and so on in the Midwest. So I'm going to pass it over to Rachel, who can talk a little bit about what we've done.
Thank you, Whitney. Good morning, everybody. And I'll also add, for folks who are in the back of the room, there is a row up front that they had reserved for speakers. Please come and take the seats if you would like, in case you would need to get a seat. Hello, I'm Rachel Harrington. I use she, her pronouns. I am a short white woman with brown hair in a blue floral top. And I'm excited to sort of expand on what Nikki shared around how we got to the guiding principles that we'll discuss in a moment. So, starting off, we wanted to recognize that we were walking into this work where there was already a very diverse ecosystem of ongoing activities, both headwinds, tailwinds, and winds of direction unknown, coming from the information technology space, from the payer side, from the federal and state regulators side, the private organizations, the health systems, the plans, and others who were already doing this work and trying to navigate a really complex set of questions in terms of what metrics do you select? How do you evaluate differences among your population? And how do you display and communicate it in ways that can provoke action in your organization while aligning with many of the requirements that were starting to be put in place by state Medicaid agencies, by federal partners at CMS and others. So we knew we were walking into a very, very active space. That is echoed in the range of inputs that we brought to this work. We wanted to get to a shared common best practice. And we realized that no one best practice could be deeply prescriptive and meet that wide range of stakeholder needs that were in the field. But we did see the value and need of coming to a set of common, agreed upon minimum best standards or starting points. We didn't want everybody to be doing this 50 different ways. That doesn't help us have aligned action. It doesn't help us have efficient action. And it doesn't let us compare what's working, what's not working, and where things are going. So we wanted to integrate the importance of federal and state policy efforts. We did not want to start from scratch. We wanted to learn from what organizations were already doing, leverage existing frameworks and thought leadership in the field, and provide sufficient flexibility that the range of organizations represented in the accelerator and represented in the broader community could pick it up and work with it. So Nikki mentioned that we had the opportunity to leverage IHI's network through the Leadership Alliance and also through the networks of all of our organizations to reach out into the field and ask, what are you doing currently? And in the lead up to this, we had already started to coalesce around some principles or topic areas that we knew really frequently came up. I already mentioned some of them: metric selection, stratifier selection, how you evaluate differences in populations. And so we put that out and we got 28 responses, which doesn't seem like a lot, but when you think about the effort that it takes organizations to really dig through their equity measurement strategies, what measures are they using, what different payer and national and state requirements were they balancing, we were actually really excited to get this level of response. We asked about their organization type, what metrics they were using, the methods that they were using to evaluate those metrics. This was a very nerdy survey. And we also got into some culture and incentive questions. How were organizations institutionalizing principles of equity? It's not just the data, it's everything else that you're doing to create a foundation to act. So a little bit about our survey respondents. I mentioned there were 28 of them. Around 7% were identified as coming from hospital perspectives. Around 11% were health plan payer. Many were from community-based primary care provider perspectives, around 20%. And then the majority were from the integrated healthcare system perspective, around 60%. We took the response from that survey. We paired it with thematically transcribed insights from the interviews and the focus group roundtables that we held as part of the Leadership Alliance retreat. And then we married it up with a literature review that was really focused in on what best practices had already been put forth in the field, what measurement frameworks, what guiding principles, what designed programs we could take and integrate. So we took the real world insight of what was happening as of fall 2023 on the ground from the surveys and the focus groups. We married that with some of the best practices from the published literature and then synthesized it into the retreat workshop that we had earlier this spring, where around 19 different organizations came together really to talk through, okay, what do we elevate and bring to the top? What guiding principles do we want to try and put out that might be helpful for organizations along this journey? And so with that, I will pass it over to Whitney to talk through where we are now.
Switch. Hi, Whitney Haggerson. I am short, but made a little taller with some heels. White woman, red hair, and a white and blue dress. She, her pronouns. So thinking about where we are now, as my colleagues have mentioned, coming together in retreat was incredibly valuable in saying, all right, how do we take everything we've learned and move forward? The selfish part of me said, I work for a healthcare system that operates in 7 states. We have 7 different states coming up with 7 unique frameworks, plus our federal framework, plus whatever our payers are going to come up with. I mean, we could spend all of our time just building and monitoring metrics as opposed to doing the real actual work to reduce the inequities for the patients that entrust us with their care. So as we came together, the energy was much like the energy in the main session this morning, right? We were surrounded by our people that care about this work deeply and that want to see it succeed. And as we got in, we realized we all had slightly different views of what we were working towards. And so it was really important to figure out what is the purpose of this guidance and who is it being produced for? We can't be everything to everyone, but we wanted to be really clear as people take this white paper, as they take this policy framework, what's the goal of this? And it's really intended to help guide and inform the production of outputs for organizational quality and equity teams, clinical and C-suite leaders, and boards who make strategic decisions. So again, thinking about who this audience is, this isn't purely academic. We really wanted to make sure that this is helpful for organizations like yourself who are either midway through their journey or early on in their journey and wanting to make sure that they're developing a framework that's going to work in helping to move this health equity work forward. We also said, gosh, we probably better align on our definition of health equity as well. I think if you've seen health equity at one organization, you've seen health equity at one organization. And so ultimately, we aligned pretty easily around the definition here on the screen from the Robert Wood Johnson Foundation. I won't read the whole thing, but specifically focusing on health equity, meaning everyone has a fair and just opportunity to be as healthy as possible. And so that was the framework for how we started our time together. Additionally, we also said, how do people get from where we are to the outcomes that we're ultimately seeking to drive forward within our organizations? And in partnership with our colleagues at University of Chicago Medicine, we decided that we would focus on this roadmap to advance health equity that will take us from identifying and diagnosing inequities through to designing and implementing programs to actually move the needle on them. For the purpose of what we'll talk to you about today, we're really focusing up here in this top box, which is specifically around identifying our metrics and the inequities that we're going to focus in on. So, so we talked a little about the survey. What Kristen and I are going to walk you through is some of the high-level themes that we heard back from the organizations that responded. Specifically, we focused in these 7 domains: metric selection, population selection, stratification, comparison and benchmark, characterizing the gap, confidence, and then culture of equity. And it was really important that we align on the nomenclature that we would use as we put this guidance forward. And specifically, what you'll see here is, while this initially was very clear and concise in our head, there's a lot of overlap in these domains. And so we'll talk to you a little bit about that as we head in. So I'm going to focus on the first 3 domains, specifically around metric selection. As you might imagine, hearing from 28 different organizations, well, there's quite a bit of variation, but also quite a bit of similarity. What we saw was that the metrics that folks are measuring specifically depended on the type of organization that they were, but also spanned what you think about as the patient journey, right? When we think about healthcare, from coverage to outcomes and experience and access, as well as safety and social determinants. One of the things that we aligned on were some selection guidelines that we should be focusing on, right? When organizations are deciding where they're going to focus their efforts. One of the big things we talked about was prioritization was key, right? We all have limited resources. If we try and measure and monitor 100 metrics, we're probably not going to be super successful. And so specifically when thinking about how do we select where we'll focus, we agreed on the 5 guidelines that we see here. So what's the prevalence of the inequity? What's the size of the disparity? The strength of the evidence. So if we see it, can we actually do something about it? The ease and feasibility of improvement, right? Is this something that is within the span of control of our own organizations or the healthcare industry? And then specifically the alignment with our regulatory and payer partners. We also then talked about population selection. As you might imagine, we saw a variation in the populations that are focused on depending on the metrics, right? So one of the conversations that we had was about the fact that it's highly unlikely that our population can remain consistent, right? So if we're looking at things like access, we're probably looking at a population of the communities in which we're operating in, where if we're looking at quality, we're probably talking about an impaneled group of patients. And so we talked a lot about making sure that where possible, we're aligning with industry definitions. So things like HEDIS, but more importantly, that we're being very clear about who's included and who isn't included in the metric. So we get the good framework for who we're talking about. And then specifically, we also talked about the fact that just standardization, while ideal, is not always going to be possible, just given the metric that we're focusing on. And then last we talked about the last one that I'll cover is that we talked a lot about stratification. What you're going to see here is quite a bit of overlap with some of the other domains that Kristen's going to talk a little bit about later. But specifically talked about the fact that data should be stratified, right? And that's not just probably by one domain. We had a lot of conversation here about intersectionality and ideally our ability to kind of zoom in and zoom out on metrics, right? So maybe starting first with race and ethnicity and then being able to break down those subpopulations even further, maybe by payer, maybe by language spoken. And I think this is where we initially got caught this last time we came together at the CMS conference last year, was thinking about intersectionality. I'm saying, oh gosh, our organization isn't doing that yet. How do we come up with a standard? So when I talk to Kristen about what they're doing at Sutter, we can get a sense of, are the same populations experiencing inequities, and is what we're doing actually making them equal? So Kristen, I'll pass to you to talk about the last 4 domains.
So great to be here with you all. So I'm Kristen Azar. I'm a Middle Eastern American woman with curly, dark, short hair, wearing a white Philly shirt and black pants. And I go by the she series pronouns. So as Whitney mentioned, I'm going to walk through the next 3 domains. And I want to just mention that these domains are distinct. We have a lot of discussion about them, but there are some overlap that we hope that we can actually engage you all in helping us to untangle as we go into the activity later on. So when we think about the next 4, it's comparison and benchmarks, but then the next one, domain 5, is going to be characterizing the gap. And the one after that is confidence. I just want to mention that because you can think of this first domain as what is the performance goal that we are setting? What is the way that we define best practice, or I know we refrain from using militarized language, but the target or performance target. Domain 5, as you think about what I'm sharing with domain 4, is really about how do we then decide what is the difference that we're interested in, and how big of a difference is a concerning difference. How do we prioritize? And then the third piece with confidence is how do we know that difference is not due to random chance? So think about that framework maybe as we walk through. So as I mentioned with comparison and benchmarks, we think about how do we establish that there is some kind of a metric or a goal that we're going for. Do we look at comparisons between the best performing group, as we've often seen, for example, comparing to the white population is something that's commonly done and that we're trying to move away from for a lot of reasons. There was a great Viewpoint article that came out just recently that one of our accelerator colleagues shared in the DMS Quality and Safety Journal that was called Interrupting False Narratives, Applying a Racial Equity Lens to Healthcare Quality Data. And this was by Harrington and all. It was just released, I think, this month. But it really goes through this process of thinking of, well, what are we doing when we use, for example, a white comparison group, where we racialize these metrics overly and take away from the root causes and the underlying drivers that result in the gaps that we see. And so also thinking about, can we leverage benchmarks that exist? So national benchmarks around the HEDIS metrics, for example, P90, should that be our goal? Should we focus on improving quality and reducing inequities across a subset of the population as opposed to the overall population? And then thinking about the value in looking at incremental targets, leading lagging groups. There are a lot of just different ways that we could think about this. So when we go to domain 5, it's really about characterizing that gap. So once we have that performance goal, how do we then think about how far different groups or whatever group or the population we have identified or defined is from that performance goal? And there are different ways to think about this as well. So if there is a gap, in what ways can we think about it in terms of clinical significance of the communities that we serve, statistical significance, which gets into the 6th domain, which I'll go into in a minute. And then how do we, think about these in terms of relative differences versus absolute differences or disparities? And just thinking about also, what makes a gap important to us. So the severity of the metric that we're measuring, for example, if this is a metric that is around something with a high mortality rate, a smaller gap may be more important, or maybe something that we need to prioritize as opposed to a more chronic or process metric that is not as severe in terms of clinical impact. So all these things add to the complexity of the way that we think about setting up our metrics, our health systems, and our different entities. And the final domain the next domain in that triplet that I mentioned is confidence. So this is where we bring into that idea of maybe some rigorous analysis or a little bit of rigor into thinking about, is that difference or that gap that we see due to random chance, or is that due to a real difference between two groups that we're comparing? And this is a difficult one, and actually brought a lot of really rich conversation in our retreat in the accelerator group, because it gets into this idea of small numbers and looking at smaller populations and how to make sure that those voices are at the table in these discussions if we're going to create guidelines for how small is too small of a cell. For example, if you have 5 patients that are meeting the criteria for your group or your population of interest, or have a very severe disparity, but it's a very small group. When we think about the backdrop of limited resources, needing to really be realistic about how we prioritize resources in our healthcare settings, it gets a bit tricky with how to make sure we don't lose sight of those groups and those opportunities and those needs, but also bring in that key audience that we mentioned earlier in the strategic planning and the decision makers kind of looking at the bigger picture in the health system and the healthcare context. So we are working on these now. the last domain is around culture and equity. And this is another one that I think is a very rich domain and that we hope to address in this guidance document, as thinking about what is the environment necessary to be able to be successful in not only putting these metrics on a dashboard, but actually closing these gaps and actually having action and resources and attention and making this part of what we do as quality and safety practices in our respective areas of the industry. And so culture of equity, we have a list of over 15 approaches, and you can see here listed the different parts of our work that it touches on, including things like leadership and representation on our boards and reflecting our communities, engaging our communities, employee training and engagement. And so it covers a whole host of contextual factors that we really need to keep at the forefront as we think about this work, and not just focus and hyper-focus on the metrics themselves, which sometimes is what we do and seems to happen. So in terms of where we are now, so as mentioned earlier, we have had a bunch of inputs. We had our work from the CMS conference last year. We had our work throughout the summer. Our work with the Accelerator and the Alliance in the fall, the roundtables, all these inputs. And so now we're taking all of that and synthesizing it into some preliminary guidance. And the way that we're doing that is using an approach where we have a framework where the advisory group that was mentioned has thought through what would be the most restrictive and least restrictive way to do this. So restrictive meaning prescriptive. So if we were to have a set of rules and have everybody in the industry follow it, what would that look like? And what would it look like to have a maximum amount of flexibility within your respective area? And then with that, we have a section of this framework for, okay, now that we know what kind of the boundaries are we're working with, what would be the ideal case in your setting? And so Accelerator members are now looking at those contrasted restrictive and least restrictive options, and then giving feedback on what would be ideal in the setting. And we hope to then take all of that and then come up with finally this first draft that we can then share with all of you for wider feedback. We're also doing things like ranking. So if we think about suggesting a metric set, what metrics or types of metrics would be more important than others? I don't mean to say importance in terms of value, but maybe even feasibility wise, what would be most realistic? And then we're hoping that with that first draft, we can come to some kind of a consensus with our accelerator group, and then we'll share that out with everybody for further feedback. And I just want to stress that what we're trying to develop really is a floor, not a ceiling. So that CMS conference, the CMS conference last year, the panel that we put together was really focused on highlighting best practices or innovative practices in measurement, which is how we came together to share those really shining lights in the field. But we don't want to stifle that. We want to continue to have everyone to think about these metrics more innovatively and to come up with things that really are things that will drive us all forward as an industry. But what we realized with first the Vizient survey that we designed, and then also the follow-up survey, is that just the level of variation is counterproductive to our collective goal of really coming up with national standards and best practices and best performance. And so that's really what this is about, is coming up with a minimal floor and baseline for us all to agree to follow. And so next steps for that will be that we will review the input from our accelerator team. And then we're going to put this together in the guidance document, which we hope will be very accessible and practical and not wordy and lengthy. And then hope to share that out with as many of you who are willing to read it and provide feedback and pressure test it in our communities, partnering with our patients, and then also other partners in the industry. We want to incorporate that feedback. Hopefully that will happen more towards the fall as we come to this first draft. And then we want to finalize and disseminate it hopefully by this time next year. So that's the goal. And if anybody is interested in being more, active in this process or learning more, please do reach out to us afterwards. We'd love to connect with you. And I do want to pause at this point and just kind of open up to any questions about our session before we move into the next part, which is going to be the interactive activity. Yes.
Hi, my name is Anita Gudvos. I'm the Director of Policy at the National Alliance of Mental Illness. And so I know you didn't get it specifically into the measures that we're looking at, but just wondering what role would mental health this play in this? Because I know that a lot of these conversations on health equity measures tend to be our physical health, like cardiovascular and things like that. So, yeah, we'd love to hear a little bit more about mental health and especially integrating mental health and physical health and how that relates into consciousness.
Oh, yes. So the question is, how are we incorporating mental health metrics and needs into this process? Thank you. It's a great question. So one thing we noticed as we were talking about metric selection was that there were a lot of really valid and important points that people raised around pediatric metrics, mental health metrics. Like, how do we make sure that we are creating a set that is, that resonates widely, but also allows that flexibility? And so, I hesitate to give the full kind of sneak peek at what we have drafted, but one thing that we have proposed is to create a metric set that everybody follows. So it may be a different mental health metric in whatever setting you're in, but you have a mental health metric that you're working on in your organization. And having everybody agree to that metric set may be the way that we start to create this synergy, but allow for the flexibility within each of our different respective areas. Because, at Sutter Health, we may be working on perinatal depression screening, but in some other setting, it may be, substance use treatment or something along those lines. And so we don't want to, it's really a challenging balance to not stifle what, the flexibility that's needed, but also create some kind of way that, consistency across our different industries.
I have a similar question. My name is Natalie Ocean. I work at a digital health startup called MedHall. We focus on transportation access for patients to get to and from appointments and clinical trial studies, et cetera. So I'm curious to know, outside transportation specifically, but just in the social determinants of health space, what kind of considerations you all have been taking into how it's contributing to the health and research you're looking to measure?
Yeah. Do you want to?
Yeah. Okay. Well, we could chime in. Yeah. So I think similar to mental health, right? Likely one of the domains would be social determinants, right? So we would pick a social determinant metric. But we also had a conversation about how do we stratify folks, right? Are we also, besides our demographics and how we identify, are we also stratifying individuals based on the social determinants that they are screening positive for, right? That they're self-selecting to say, hey, I have a challenge with this. And so I think it's a little bit of a both and, right? It will probably a focus of the metric selection, but also potentially one of the domains in which we view our patient population from.
I would also add, I just went back quickly to the framework that we're working with, which has been hugely helpful in putting this work into context of the bigger picture, where we're really right up here, right? We're just the beginning of identifying where the gaps are. But social drivers really come into play, not just in the metric piece, but in the root causes and trying to close the gaps and informing the interventions. So as we think about that next step on the roadmap, you will need to think about how do we actually understand what those social drivers are, why we're seeing the gaps that we're seeing. Does that make sense? So this is hopefully going to be part of a bigger effort, and we hope to get this guidance document done, then moving on to the next one of how do we do root cause analysis? We're all doing it differently, especially around health equity. And thinking about some of those opportunities as well.
Mm-hmm.
Any other questions? Questions. Excellent. My name is Julia Manti. I work for the Michigan Value Collaborative. So we actually rely on claims data from Medicare, Medicaid, and commercial providers. So a big benefit of that is that we are able to analyze what patients do over time, regardless of what system they're accessing care at. I'm wondering how much of your framework relies on data collected within the EHR that would be limited to the system a patient goes in, or you can see the continuum of care regardless of where they're accessing care at.
Do you want to take a first pass at that? So I think it comes up in a couple of points. We keep coming back to this metric selection question and having maybe set, not the technical term, buckets or families of measures that we expect, but the actual measures themselves will vary by organization. So if you happen to be in a setting where you have that continuous claims view across different locations and systems and so on, pick a measure that goes with that. But if you are a hospital or you are an FQHC or you are a system, and you might just be working from your EHR data, which has its pros and cons, right? Then you have a metric selection question there. You might still want to make sure you have that mental health, behavioral health metric, you have the social needs metric, but you might pick slightly different ones to be able to fit that. I think this also comes in with the question of feasibility and prioritization, right? And some of the really tough questions that we're hoping that this guidance can help organizations navigate in terms of, if you can't do it all, what is the level of effort that would take to stand up X approach versus Y approach? What populations does that speak to? And how does that help you achieve your equity goals? Understanding this will evolve over time.
Yeah. I think one of the great conversations that we had is just even the resources that vary across our organizations, right? With the complexity, do we have data scientists, or are we working in an Excel document, right? And so I think that's also something that we're trying to take into consideration, is that we want this to be approachable to all organizations, regardless of the resource that they have. Because if we aren't looking at equity as part of our quality efforts, we're going to continue in the direction that we've been going, where, great, we're performing at P90 on our, HEDIS metrics, but when you actually get in and stratify, you're like, oh, that tells a very different story. And so part of this is also just trying to meet organizations where they are.
Yeah, I think it was, sorry, Chris, I was just going to say, I think it was really telling when we did the retreat and we were doing this roundtable exercise, and there were 3 or 4 organizations around the table, and we were talking exactly about that. What are the resources that you bring to these efforts? And somebody was describing, we have an analytics department, they do this. And then somebody at the table was, it's me. And so, as much as from the innovation side, we know there is so much that can be done with data and predictive analytics and stratification and risk settings, that we want to make sure that this is accessible to the it's me. To the organizations who are really passionate about this work, need to do this work, want to do this work, but maybe have that one person who is slicing and dicing and doing all of this. And so really trying to support that baseline of how do we get to a best practice.
And we have that very much in mind, even if, the confidence conversation inevitably brings up statistical, significance analysis. And if we do represent that in this, we do hope to provide some guidelines on how to do that, or some basics, really demystify it and make it something that's attainable, so that this is something that's very useful no matter what level of analytics you have access to in your respective area. We're looking us to the activity. Can we take one more question?
You can come back to it.
No, I see. Okay.
Can you?
Oh. It's up to you guys. To the panel, you decide.
Yeah, maybe one more while we're setting up the tech, and then we will have time for additional Q&A after some of the exercise.
Hi, my name is Rebecca Sanchez. Yes, that's my real name. You mentioned, I heard somebody mention a dashboard as a potential output, and I was just curious. And sorry, I run from the adult equity question, and we do a lot of the data stratification, role setting, data access, and we see people fear point people with big health systems with Excel spreadsheets and analytics feeds. So curious how you're going to make your output accessible. Because if you can talk more about dashboard based.
So we are not trying to create one all-encompassing dashboard. We're trying to facilitate the creation of many dashboards wherever you are. But what goes on that dashboard is really what we're focused on, is what do you include? How do you measure it? How do you represent your gaps? So any dashboard that, is represented from those in this room has some kind of a framework that it follows. That's the goal. That makes sense. So we're trying to create the architecture for dashboarding in our industry for health equity, but we're not trying to create an actual dashboard that everybody can bring. So that's the whole balance between most restrictive or prescriptive versus that, completely flexible approach. We need to find that middle ground where we have a framework and allow flexibility within it, if that makes sense. And there may be some synergies.
Yeah, and this may be a big, hairy, audacious goal, but part of what could happen as a result of this is to have policymakers lean in on some of this guidance, right? And then maybe they're the ones that are creating that dashboard that enables us to look across organizations doing this, right? So maybe I can't compare to Sutter because we picked a slightly different mental health metric, but I can compare, to a Mayo clinic. And so I think that maybe that's steps down the road. And if I had a wish for this, that it would be that, somebody like a CMS would lean in on this and actually be able to help facilitate that monster dashboard.
Absolutely.
All right. So we've been promising and promising an interactive activity. And that's what we're hoping to transition to here. So for folks in the room, if you have your phones out
And online.
if you have the slides, there's a QR code on the screen right now. If you scan that, it should go to a site called Mentimeter that will have some polling questions that we'll go through. Now, because technology is both our best friend and our enemy, we aren't showing the live results on the screen right now, but we do have them pulled up. I'm going to verbalize the question. You'll see them on the app on the screen, and then we'll talk through the results and really see where we're finding people are agreeing and where people might not be agreeing, and using that to tease out some of the concepts. So if we open up the first question, there will be two questions together. One is on the characterizing the gap topic, and the other is on the confidence topic. And it's a slider asking you to kind of write in, do you feel like you clearly understand the intent of characterizing the gap? And do you feel like you clearly understand the intent of confidence? Those two separate but related domains that Kristen talked through just a moment ago. Characterizing the gap should be evaluated across factors, numerical differences, how we're making comparisons. Confidence, data should be ensured through statistical methods or the concept of clinical significance. So I'm looking.
We have 201 respondents, 215 people in the poll.
All right, go ahead and close that one. And I'm going through this one a little bit quickly because we have some that dig into this. Think of this as the warm-up exercise. All right.
This is the distinction between characterizing it. You want me? Here, you take it.
Oh,
If you know, just advance when you want to advance.
All right. So we're seeing that the characterize the gap really increased clarity. There's generally
Oh, no, you have to go back. That was the previous one. I'm sorry. And you said advance.
Oh, there we go. So characterizing the gap in confidence, generally 6.5 out of 10 folks are feeling like it's fairly clearly defined in terms of this. But then we went to the next question. Does the distinction between characterizing the gap and confidence as a separate domain, so having those as two separate concepts, does that increase your clarity, decrease your clarity, or neutral? Doesn't really make a difference, kind of where you were when you walked in the room.
And maybe we should add, we're asking these questions in part to inform how we set this up in the guidance document. So when we were talking in the retreat, there was a lot of kind of going back to those domains when another domain was brought up in a circular discussion. So should we keep these together and kind of talk about it together, or should we have separate kind of, sections around these things?
Yeah. And this is the one I was hoping to get to and wanted to pause and discuss for that reason. So we're seeing about 160 out of 300 respondents saying that the distinction increases clarity. The next most common response is, I'm neutral. So there are about 10% of folks who are saying it decreases clarity. The reason we wanted to bring this up, and I want to take a moment to pause here and maybe get some reactions from in the room, is when we sat down with folks to walk through this, we kept ping-ponging back and forth. We would talk about what comparisons we were making. We would immediately hit questions about sample size and reliability. That would take us into the discussion around, well, if the p-value isn't statistically significant, can I convince my C-suite on something? Which would sort of put us back to, well, what comparisons are we making? How many groups can we compare at once? And so on and so forth. And I'm seeing nodding in the room on this, and that seems to resonate with many of the folks here. And so, as we think about this, what we're trying to judge is, even though these are highly related concepts, is talking about them separately helpful in the sense that maybe you want to characterize the gap a certain way, you want to make comparisons, and confidence, statistical significance maybe applies to some of those decisions, but not all of those decisions. Maybe it's important to be making comparisons that don't reach a p-value of 0.05, but are still illustrative for your populations and for the work that you're doing and for the prioritization work that you're doing. So I'm going to use that to lead in to a discussion here, which is how important is the contribution of statistical significance to the interpretation of equity dashboard metrics at your organization? And I'm going to give this a second for it to comment. Now, statistical significance to the interpretation of equity dashboard metrics for your organization. You can think about it in the context of today and the metrics that you're producing and the evaluations that you're doing today. What weight are you putting on significance from no priority, low priority, medium priority, or high priority? I'm going to give this a moment. The responses on this one are coming in a little bit slower, which I think is very interesting. The others were pretty quick. People were like, yeah, it's this. Here, it's a little bit different.
Do you want to clarify what statistical, does everybody hear?
Does everybody understand?
So it's applying a test, a mathematical test or a statistical test to your data to show that there is a difference that's likely not due to chance.
Mm-hmm.
So some organizations don't do this at all because they're not the analytics to do this, or there just isn't an emphasis. Some organizations solely rely on that to prioritize resources and work. So just wanted to clarify that to understand how you all think about that. And does this resonate with some? If not, it's totally okay. We're just trying to understand how much to emphasize this in the documents.
Well, and can I add too that we've heard from some organizations that sometimes the sample sizes that you're working with are so small once you've stratified that you can't even apply mathematical tests of significance. How does that impact the strategic prioritization?
So I'm going to read out the results here, and then I see some hands up in the room if we have the mic that can go to the questions. There's a few over there, and then there's one up in the front as well. So as we're getting that set up, I think there was a person in the middle of the row there. What we're seeing on this 1 no priority to 4 high priority, about half of the responses say 3 medium priority. I'm a researcher at heart. I intentionally did not give a middle ground. It's a 4-point scale, not a 5. So we're seeing that the bulk of responses tip towards medium or high priority, around half medium and around 100 or a third at high. So this is something that from responses here are being deemed as important. So let's dig into that a little bit. And I'm hoping we can with the comments or the questions in the room.
Hi, I would encourage you to ask that question to stratify our audience. I'm from a national organization, and I think some of the other commenters are too. So if you are a provider, if you're a hospital or hospital system who's really trying to impact your community, it's a different question than if you're a national organization trying to make a point about what should be done to address things. So if you split it, I would guess you get different results.
Good testing. Mm-hmm. All right. I think there was one more question here, then up in the front.
Just to piggyback off that comment, so I'm Shivani Yakumov, the Student Director for Health Equity at Washington Medical Center. So exactly that point, I think we are not looking for PD 0.05s, no less than. We're looking for impact. Right. So my confidence in a measure is how much is it going to impact by community, whether it's 5 people that are taking up the proportion of readmissions and money in my institution, average 1 that p-values, versus, a very, very large 40,000 person population where everything so looks significant, right? If you look at half and slice it up. So I think we're getting, and I would just say one last thing, because I'm a researcher on CART as well, the statistical background, the p-value conversation is like blowing up even in the statistical field, but it's not necessarily the most impactful. So anyway, that's
all right. Well, I comments here.
Thank you so much. It'll be brief. I really appreciate this conversation. My name is Alyssa Wassong. I use she for pronouns. I'm the Executive Director of the Food as Medicine Coalition. So if you took my question, thank you so much about simple determinants. So we feed people across the country medically tailored meals. And my question is one question in that comment. The question of how qualitative research, gathering, information, conversations comes into this idea of moving the needle, because that's not where p-values live, right? And then the other part of it is from a sophistication perspective, p-value don't always enter into community conversations. That's not how CBOs and the social determinants piece of it are collecting information potentially, or even able to evaluate it. So that would require more capacity, I would say, and in designing something that's usable across for everyone is just something to consider. So I really appreciate this conversation. It's so great.
I think that's a great point. And it's come up a lot in the discussions we've had. We intentionally bit off the question of metrics and measurement, which is a quantitative exercise in many ways. But every conversation we've had, every survey we've done, every single one of them has said, you cannot do this without the qualitative insights as well. If you are measuring something and you are not getting those insights from the people who are experiencing the measures that you're showing, you're missing the mark. And so for us, like we're showing some questions, not on the screen, on your phones, that are focused in on areas that have been particularly crunchy. There's been tension, there's been discussion, and areas like that of you got to put your qualitative with your quantitative. That's not where the conflict has been. I think everybody's been pretty much on the same board on that.
Yeah, I'll add to when we think about this domain, the three of them together, something that came up was this idea of there's statistical significance, acknowledging the confidence interval, and that it very much simplified it to be able to have this conversation. But statistical significance, clinical significance, and community significance, and try to think about how could we incorporate all three as part of the guidance? And do we have a situation where we recommend doing all three, or do we defer to whatever is typically the driver of how you think about prioritizing, the metrics that you choose? So that's very much also a part of that discussion. And as Rachel shared, this was the biggest discussion point, the metric selection part, all that stuff we sailed through. Actually, we were surprised. Like, oh, wow, we're good. And then we got to this conversation, and we'd love to hear your thoughts on, how do we do that as an industry? How do we think about bringing in some qualitative elements in a way that also recognizes some limitations that some have as well, right? And that those resources or those capabilities, how do we engage our communities when we have such variation in capability to do that as well?
Yeah, and I'll add, there's been a question in the back there, if we can get the mic to the person with the hand up. But I do want to add, as we're discussing this and we're pulling all of this qualification around the idea of statistical significance, 2/3 of the survey responses said it's a medium or high priority. So there's an element here of translating for those who are in the room, who are self-selecting to be in this discussion. We sort of default. There are all of these other elements we have to consider. But if the audience for some of this is a C-suite, E-suite, if it's a board, if it's an audience who's used to looking at business metrics and not necessarily the sort of broader qualitative constructs in play here, how do we translate that conversation? And that has been some of what's come up around this discussion. All right.
Dr. Shimon, my assistant director for the health impact for Advanced Conversely Health. I just wanted to point out that there's an underlying assumption in your question that I don't hear anyone else addressing. So I also work for a multi-state, health system, and I myself am a recovering academic, but most of them in my system aren't. So this underlying assumption that you made is that there's a capacity for generating a handout. So when you start talking about how important is it, well, when I can get it, it becomes important. But a lot of times I can't get it because I don't have a statistician on staff to help me generate it. So it would be great to be able to get there. But I just wanted to point that limitation out, especially if you're in a health system that's not connected to an academic institution.
Such an important point. And I think one of the things that we talked about is if we do move forward, and that is part of our recommendation, how do we outfit people with tools, right? How do we simplify this? Is there a template that we can drop data into, right? And because I think it's the same across the board, right? We don't not necessarily all have the ability to do that, nor do people that are interpreting the data have the understanding of what does that mean to me, right? And so I think that's another big component of this is how do we also build capacity of our infection preventionists and our analysts to understand that as well.
You see a star and it means importance. I see others in the room. I do want to check, are there any questions online that we want to bring into the conversation? I don't know if any have been submitted.
We can go to the question.
All right. Not seeing any. We only have a couple of minutes left. There was another domain. We wanted to get a little bit of insight on the culture of equity domain. So I might ask for those who still have questions around the confidence or really want to engage with us, there's going to be another QR code. You can get in touch with us and also just find us here after the session or at the conference. So briefly, just to, again, temperature checking the room, culture of equity, creating a culture of equity within organizations involves leadership commitment, governance structures, reducing implicit bias, and workforce diversity. How much do you feel you clearly understand the intent of the culture of equity domain? I'm going to give this a minute to come in. Man, folks are fast. This is awesome. All right. We've got a little bit under 200 responses. We're seeing scores of 8 out of 10, 10 being highly understand and so on. So this is great. Like this buy into the idea that metrics can't be the only part, that you've got to have that foundation under it. So what I might do is I'm going to, if I skip a question, skip a question. Perfect. So I'm going to go to the last question. As the guidance is finalized, thinking about this culture of equity and all of the different concepts and constructs that might be in there, how much flexibility do you think is ideal to support you in developing, reporting, and making decisions on this? 1, no flexibility. 2, low flexibility. 3, medium flexibility. 4, high flexibility. Interesting. All right. So we are seeing, again, a little bit of slower responses on this one, but about 200 responses, around half of those responses are saying medium flexibility, while about a quarter are saying high flexibility. So we are leaning towards the more flexible side of things with this.
That's good. Good information.
Yeah. So I'm curious, for those in the room, as you think of this concept of culture of equity, how we define a minimum bar, a baseline, any final thoughts that you might want to add to this discussion as we move forward with constructing this domain? Yep. See a question in the middle here?
Advance to the question slide. Go to the question slide.
Oh, I think it was Anna.
Yeah. Let me take this.
Thank you for the wonderful discussion. Anna Soares, Medicaid Policy and Data Lead at the Library. A couple of thoughts, because I think this goes back to the confidence domain. It just keeps coming back to me. It might be that you focus on confidence, that's the label, but what I'm taking away is that the most important thing is that people define how they are interpreting their data. That's the most important thing. You in the discussion focus on statistical methods, but clinical significant gap is a very different animal. And it was also abundant. And so I kept thinking clinical significance. And that's why it's important to find what you consider significant and why it's significant for your organization, your objective. And the other one is, epidemiologically, if you move the needle just this much, but it's for 1 million people, that's also clearly important. And so that explanation, the definition, and an identification of your objective and how they align seems really important.
Got it. All right. Well, we're getting the signal that time is up. Thank you, everybody, for the interest in the room. Please keep in touch. This is something we're going to be continuing to work on over the summer. I will leave this up, but also in the slides are the ways to get in touch with each of us in terms of follow-up questions. Also, if you happen to spot us, flag us down.
Come say hi. Thanks, everyone.
Thank you all.
Great here.